I don't know. Welcome to everybody. Welcome to the World Cancer Congress Big Debate. We are going to be discussing, is AI in cancer control progress or peril? AI is increasingly integrated into healthcare, offering significant advancements in diagnosing diseases, tailoring treatment plans, providing psychosocial support, and taking on and supporting the management of administrative tasks. However, the rapid adoption of AI also introduces critical challenges, particularly concerning patient data privacy, the necessity for ongoing human oversight, and the development of robust regulatory frameworks. In this debate, we're going to explore the dual facets of AI in cancer control, the potential to transform care, and the imperative to uphold safety and ethical standards. So the way that we're actually going to do this is we're going to have a poll right at the beginning of the session to see how everybody feels in the audience at the start. Is AI progress or peril? Then we're going to have a discussion from our esteemed presenters, both of whom are very involved in AI. And then we're going to live poll again at the end of the audience. We're not looking for a winner or a loser. We're just really looking to see the insights and the viewpoints of yourselves and also our speakers, and whether or not those insights actually will be changing your mind. So we're actually going to ask you, our audience, to vote now, so you can share your thoughts on the topic. You need to take your phone and scan the QR code, and we're asking you to vote. Is AI in cancer control progress? Is it a good thing? Or is it peril? Are there dangers? And how do you feel about that now? And we're going to watch the votes come in. I can still see some people taking photos of the QR code, so I'm going to give you all a minute to vote.
Do you think it might change?
Okay, so I don't think we need any explanation of the results. Obviously, very much in favor of progress. AI in cancer control is progress there. That's a very, very, very high majority, as we can see. It's slightly dropping though, actually. But yeah, very, very high majority there in favor of progress. So we will see what that looks like at the end of our debate. So it's my absolute pleasure to be standing on stage with two experts who are both incredibly involved in AI professionally. I'm just going to give you a short introduction to both of them before we start with their speeches. So first of all, we have Dr. Richard Lee, who's a consultant respiratory physician and champion for early care diagnosis at the NIHR Biomedical Research Centre at the Royal Marsden in the UK and the Institute of Cancer Research. He's co-lead of the Royal Marsden Early Diagnosis and Detection Centre, and he drives screening, prevention, and early diagnosis initiatives across a number of cancer types, particularly in early lung cancer diagnosis, as joint national clinical lead of NHS England National Targeted Lung Health Check. This program pilots lung cancer screening in the eligible population of over 3 million participants across the UK. Welcome, Richard. And also I'm delighted to welcome Kingsley Endo, MD, MPH, is the founder and CEO of Huron AI, Seattle-based medtech startup pioneering the use of culturally sensitive AI technologies in oncology. Huron's technology improves cancer care delivery, significantly boosting efficiency and effectiveness for oncologists. The company leverages advanced AI and cloud technologies to ensure scalable, secure, and robust healthcare solutions. The company's commitment extends to improving access to personalized cancer care and advancing biopharma research, particularly for underrepresented populations. They actively contribute to global health equity through strategic partnerships with leading medical centers and research institutions in the US, Brazil, Nigeria, Kenya, and Rwanda. Welcome, Kingsley. Thank you so much for being here. So, first of all, we are going to hear from Richard Lee, who is going to be arguing that AI in cancer control could be peril. Over to you, Richard.
Wonderful. Thank you so much for the invitation, and thanks all for listening. I hope this will be a really interesting debate. So here are my declarations. I do collaborate with a couple of AI firms. So I'm surprised I've not seen this graph already. Whenever you go to an AI talk, you always see this hype graph, right? So we're, I think, pretty firmly at the top of that peak of inflated expectations. We've got radiomics, we've got ChatGPT, we've got treatment field planning, and essentially this is a huge amount of investment. One paper suggested that for 11 new AI products, there might be $1 billion invested. So thinking about, are we really focused on patient benefit at the moment? Are we focused on cost effectiveness, or are we focused on profit for industry or the shareholders? We have to recognize that whatever you see on the slides today, there's going to be at least a 6-year lag before FDA approval. I thought I'd see where the clinical trials actually were on PubMed. I was quite pleasantly surprised. There are 4,000 studies just looking at that quick caption of AI, machine learning, or radiomics. 950 FDA-approved medical devices to do with AI. And we're seeing some position papers coming together from entities such as NICE. But of course, I could just look up this kind of talk on what to tell you based on ChatGPT, and it gives you a very sort of sensible sounding answer. You know, whenever you, I don't know if you've ever tried to educate yourself through ChatGPT, sometimes it's great, but then you just see these little errors creep in. For example, it thinks several dozen AI-based devices have been approved earlier this year, and that's essentially called hallucinations. So it's that mirage in the desert where you see something very convincing, yet it's telling you something that factually may not be correct. So I was quite surprised at the poll this morning where the audience were asked how many of you have a lot of AI in your lives, and I think that came back about 50%, and I appreciate lots of different backgrounds here, but really I think anyone that booked travel to come here, anyone that used Google Maps or similar to make their journey here, and even my washing machine tries to optimize its cycle with AI. And so if you type in questions into things that you know have AI backing, for example, what is a doctor, according to Microsoft Bing, it's perhaps doing well on the gender balance, less well on the racial recognition, and who actually would see a doctor who looks so smart and shiny as this in the hospital setting. Similarly, if you look at a different algorithm, so Google just searching for doctor is perhaps a bit more balanced in terms of ethnicity, but again, some of those gender biases come in. And you might think, well, that's just a frivolous situation, you know, looking at Google. But actually, if you look at some of our major data sets that we rely on, so the Framingham Heart Study, it's a study of white men in America, trying to think about how people have studied how this could be more applicable to other populations. And we see the same thing happen across other standardized data banks and blood sample banks. So of course, we're going to debate in this session some of the technical challenges, thinking about who owns the data, how can we share it safely, what is the cost of using such data. What I want to pose to you is there a bigger issue here. So if we think about one of the biggest innovations we've ever seen in history, think about the Industrial Revolution. It's completely changed our lives as we know it, but think about at the time, there's overcrowding of cities, pollution, poor working conditions, a rise in unhealthy habits. Think about the way the global economy is shaping up at the moment. Are we setting ourselves up for a considerable risk, just in fact, in the basis of how we're adopting a new technology? So I think it's important to remember there's some great innovations and some really fantastic people in the world that are driving this. But if we think about startup founders probably take home a large portion of the economic surplus that they create. Significant innovations disproportionately benefit the few at the earliest stages, and that can then lead to a concentration of power and wealth. And does that exacerbate the global power imbalance and lead to future conflict? So we have to be careful that if we abuse this kind of evolving situation with power in the wrong hands, that potentially all of our kind of health approaches might be determined by the uninformed few rather than the traditional structures that we try to create. So we have to hope that those who are developing these products are kind of recognizing what is needed by healthcare internationally. And I guess with that, is it just the individuals or is it boards of large companies that are essentially trying to prioritize profit? So that's the end of my introduction. Thank you, and we look forward to the debate.
Thank you so much, Richard. Okay, and now it is Kingsley's turn to talk to us about the progress AI.
Wow, he has shattered the table. So now I have to reorganize that table and, and advance that confidence here. I shared this slide earlier. In cancer care, patients need a lot. And even though, as he said, there could be inequities that could be perpetuated by AI, but all I see in this slide is efficiency that AI can bring. We are making significant advances in diagnosis, especially when it comes to convoluted neural networks with radiological imaging. I think about one radiologist, maybe somewhere in Accra, Ghana, that do not have the resources to review many CT scans, and AI can make that much more better for him or her. I look at the global oncologist workforce shortage, where there's one oncologist to 3,000 cancer patients in Africa, and I see AI bringing a lot of efficiency, better clinical decision making, and reduction in burnouts. This was a algorithm that was developed by one of our board members, Adam Yala, while he was in MIT. And the first image on the left was a baseline mammogram, nothing seen there. But the algorithm was able to predict that in 4 years, that woman was going to have breast cancer. And in 4 years, that was the cancer appearing. These were radiologists who were not able to see this. And that's the study. It was validated in 7 continents around the world. I see this study in 2012 in Ugandan Cancer Institute, where they had sent several slides of leukemia slides, was sent to a reference lab in Amsterdam, and there was a 38% concordance rate, which means there was misdiagnosis in over 50%. But hey, look, the AI systems is getting it even better than those pathologists. Not that they were not trained enough, but because they have so many slides to see, they're not just concentrated on one, but with all that data, AI can do it better. So we see patient monitoring, which is what a company does really well. We had 9 emergencies auto-detected in Rwanda by patients just reporting and telling them this is an emergency. 4 of that was febrile neutropenia, and any oncologist seated here know that that is life-threatening, and they were able to go and get help immediately. Our oncologist said that she saw a 60% drop in off-duty calls. Doctors just want to have good time with their families. They don't want to be having all these calls from patients. If we can use AI to create that efficiency, why not? And this is the doctor I was talking about. This is her words. It made her work more efficient. Why would we ignore that? And I see a world where we have a symbiotic relationship between clinicians, data, and AI to give us or to produce precision oncology. And I don't see a replacement. Why should doctors be replaced? One of my mentors tells me that there's nothing AI, there's no algorithm that can replace experience and human intuition. So what we see is a symbiotic relationship. And we also see this in clinical trials, rapid recruitment rates, safety monitoring, automated data analysis and reports. And if we can shorten R&D time, we can shorten the drugs, the cost of drugs, and that would increase access eventually because we all know that targeted therapies are prohibitively expensive. And so if we can shorten R&D using AI, that will reduce the cost. Who wants to be burdened with mundane administrative tasks when we can fine-tune models that can do it really better and faster? And yes, I agree with him. We need to think about data security, privacy, validate the AI, make sure it's explainable so that doctors understand the algorithm, and ensure data diversity to reduce bias. And I hope I've convinced you even more to take the side of progress and not peril. Thank you.
Thank you so much, Kingsley. You mentioned, obviously, so many great aspects to AI within cancer care. What would you say is the greatest potential of AI in cancer care, if you had to just sort of say one aspect?
I see the greatest potential in AI when in the context of crunching vast amounts of data that we don't have the ability to do as doctors or clinicians or even government administrators, where we can, for the first time, we can look at social determinants of health data, clinical data, lab data, imaging, and really not just produce precise treatments for patients, but even target the supports that patients are going to need so that there's less treatment drop-offs and they can be supported throughout their treatment. And I know you said one, but the second is also in prevention and early detection, really, really huge. That is where I see the greatest potential, that symbiotic relationship between clinicians, AI, and data.
Thank you. Richard, how do you feel about the potential of AI in cancer care? Is it overhyped?
So I think that there is inevitable potential, and I guess that hype graph, highlights how that might flux between sort of excitement and reality. I guess I sort of think about, what do we do with drugs? What do we do with medical devices? If you sort of think about how we've evolved the infrastructure over the last decades to make sure that if we think of a new drug, we're going to test it and scrutinize it, potentially randomized control trials, really sort of push the limits on, are we convinced that drug works? Think about the infrastructure around those, the companies and things developing it. So I guess the moment I see is now potentially for thinking, if we want to do AI in medicine, what safety sort of belt do we want around it? What's the infrastructure that we can build so that as we generate all these exciting ideas, how can we be sure that at the moment that it counts, we'll have those approvals in place, it will actually make a difference for the patients, rather than picking ideas without a clear strategy and without a kind of a clear infrastructure to deploy that.
Thank you. So would you say, Richard, that there are limits to how AI can and should be used in cancer care?
So I think I was trying to think about this sort of area. There's an opportunity cost, right, in everything we do. So I'm a humble pulmonologist. I've been wowed by some of the experts that have spoken at this conference that have told me about HPV vaccination, medicine in conflict areas. And so I think about, okay, we've got this chance to develop something. There are some technical limitations. I think we can overcome those. But what are the kind of the ethical balances about how we choose to invest our funding? So I think we absolutely must invest in AI, but we have to back the horses we think will win. We can't just do AI research for the sake of AI research. We have to pick the things that we think are really important clinical questions, design proper trials, have an infrastructure that we know will be successful, so that in a short period of time, we've seen an idea, we've tested it, we've proved it, and then we think about how we can bring that with parity to those in the underserved populations as well as those in kind of more technologically developed settings.
Okay. And Kingsley, do you think there are limits to how we use AI in cancer care, or are we limitless?
No, we're definitely not limitless. There are limits, and what I'll say is that we should deploy AI in a very, very thoughtful way. It should be well validated across different populations. Or if you're deploying to a specific population, it should be validated in that environment, because we need to ensure that we're not exacerbating already existing disparities. We need to see AI mitigating those disparities. And so, yes, there should be limits, and there should be regulatory components around this, and different regulatory agencies around the world are still grappling with, how to even continuously monitor products, because unlike a drug, submission to the FDA, the efficacy and safety is like kind of fixed for the population that was trialed. But for an AI application, that could change, because as it's learning and as it's scaling, it could change for the better or for the worse. So it definitely needs to be monitored, because patient safety should be number one on our priority, in as much as we want to increase access and improve experiences for patients and clinicians.
Thank you. And you spoke to this idea earlier about AI replacing oncologists, which I think is very much a lay fear as well as a professional fear. So talk to us about that, about what you think about AI. You mentioned already about experience.
It's a valid fear, but it's not the reality, and that's not what I see, and that's not what many experts see. What we see and what it's eventually going to happen is that seamless interaction between clinicians and AI and data analytics tools to make care more efficient. If you think about it, even some people think it's going to have the biggest significance or the biggest impact in emerging economies, low and middle resource settings, but it can significantly lower healthcare costs, which in the US is one of the things that we grapple with. If we can create efficiency in the system, doctors are still burnt out, even though there are so many doctors, it's still limited. So as much tools that we can have that is safe, is effective, it conforms with the clinical workflow so that doctors are not overburdened with another zillionth technology in front of them. I think it's going to be a symbiotic relationship rather than a replacement. I absolutely do not think that AI will replace. Again, I'll reiterate that human intuition, that humanness, even when you train the AI to do that, which you can fine-tune to do that, it still doesn't replace the real human interaction when it comes to patient care. And we all know studies have shown that placebo effect of just that empathy and compassion that a clinician is going to have with a patient really can be replaced by AI. What we want to do is to make care more higher quality, more precise, and more efficient.
Thank you. And Richard, do you think AI will replace oncologists?
I think that's a great answer. I'd probably be more worried if I was a radiologist. Essentially, we're going to see these things coming in, right? And I think it's about the people. So if you think about the clinicians out there, you think, how will my job change? Your walk to the conference today was no longer trying to remember the direction. You were just following Google, staring at your phone. That's fine. We got here, probably get lost less often. But I think there's then the risk of, will we de-skill in a particular way? Are we less resilient, less resilient to a cyber attack, or even just more mundane things? We can't train our juniors because we're relying on the technological devices. We're faster, but perhaps more dependent on that. And I think the other thing we have to recognize, sure, it's cheaper, but should those devices, in a way, be paying tax? So I have to pay tax, and that contributes to the system. If you replace my job, that tax is no longer funding healthcare, other key infrastructure. So we have to kind of look at the bigger impact and think about how it will change what those people do in the healthcare service, and are they happy with that, and are we really getting the best from them?
I have a quick thing to add, please.
Please.
So I agree with you that we'll need less radiologists, but I don't see it as replacing. We need more primary health care doctors. You need more family physicians. So what will happen is people in medical school, as we evolve in this technology, there will be more people now attracted to family medicine where there is need, and there will be fewer radiologists. It's just going to do a little bit of redistribution where we need it. And but yes, if for radiology, anything that has to do with visual assessment, it's AI is even getting a power even better. But again, it can't replace all radiologists. It definitely will just sort of like redistribute the different specialty interests as people are graduating from medical school and thinking of what to do their residency and fellowships in.
Yeah, that's an interesting idea. Richard, you've both spoken about disparities in healthcare in terms of AI. So do you believe AI is going to exacerbate disparities in cancer care?
I think the feeling is out there that yes, that's quite a big risk, or peril, essentially is a risk. We won't definitely see that happens. I think we have a responsibility, though, in trying to make sure we're constantly focused on, can we stop that? So, I need to do a piece of AI research, and I'm going to think, how do I most easily do that? I've got a whole load of scans related to a particular population. That's easy. But then actually, is that at all relevant to a sort of a broader population? And that's where I think we have a responsibility to try and intervene there. So I guess the question comes in, who are those populations that are underserved, both locally, globally? And again, coming back to that point, where's all the money going? Is that fair, the way that that funding's been distributed? So if a National Health Service public patient contributes their data to an AI algorithm with a commercial partnership, who owns the profit there? Is that the background IP of the AI company? But in the same way, they wouldn't achieve that or realize that AI IP if it weren't for the patients in the service. So I think we have to recognize, where does the profit lie, and how can we put some of the equity back into the system?
Okay. And Kingsley, do you believe it can address the disparities in AI in cancer care?
Yes, I absolutely believe that if AI is deployed thoughtfully and different contexts are infused in the development of the platforms, it definitely can address the disparities that we see today. For example, if you think about patients that do not have access to internet, which increasingly is now being recognized as one of the social determinants of health, there are other technologies that could be built in or incorporated to mitigate this risk of exacerbating the divide. And one of the things we've done is to ensure that patients can use USSD text message systems to interact with our platform, even if they don't have internet. What he talked about in terms of patients contributing anonymized data and where does the profit lie. One of the things that we do is when we have data that is being used to train our systems, and we attract some form of commercialization of analytics, that money or part of that revenue is shared with the hospital, with the cancer center. And that is really critical because now they have more resources to buy more equipment or to hire more staff. So if we can deploy artificial intelligence in a way that considers the epidemiology of that region and the clinical context of that region, I think we have one of the greatest opportunities of our lifetime to really address inequities in a way that we haven't done before. That being said, technology is not the magic bullet. We still need to train. We still need to ensure that we have better access to therapies, and technology can tie all that together to truly address the inequities we see today.
Thank you. So before we go to our audience, I'm going to ask you, although you're talking about potential and progress, I'm going to ask you, Kingsley, what you think is the greatest danger of AI in cancer care.
So the greatest danger to me is a rogue algorithm. So you could design a platform that is performing at this level, and during unsupervised training with more data, it goes in a direction that you didn't intend it to, and that was not monitored, and then that could definitely affect or harm patients. That's one thing. And I think I would say the second big thing is data security. If you know, if a hacker somewhere figures out how to break into AWS highest level security that complies with GDPR, HIPAA security protocols, we'll have a situation in our hands that we definitely do not want to have. So data security definitely, and a rogue algorithm.
Okay,
Yeah.
thank you.
Great.
And Richard, what would you say?
And I would add to that, it's not just the rogue algorithms that you want to worry about. It could be the very best algorithms, and all of a sudden something changes. Everyone starts smoking e-cigarettes, or the CT modality changes, or there's a pandemic. All of a sudden, the algorithm that's focused on one particular type of data no longer serves. So I think we have to be really careful in monitoring that, but even for the best algorithms. I think for me, it's about the red tape and the bureaucracy, and getting that right. Being sort of enthused about the bureaucracy and sort of making it work for us, and not tying ourselves up in knots to say we can't do AI because we might share some patient images. We have to really think about what the public issues and what the public sentiment is on that, and embrace it and be prepared with that. And then I would say not rushing ahead, not doing the research, and sort of really thinking about how can we get ahead of doing good quality trials to make sure that this works. And then finally, we must embrace equity right from the very beginning, because I think that could be the biggest danger. If we just plow ahead and make something that's profitable in a very small niche, it essentially will be useless on a larger scale.
Thank you. Well, I'm sure you'll all agree we've had very compelling arguments and insights on both sides, and now it's your turn. So we have the opportunity to hear from our audience. There are microphones in the audience, and we're going to do this in the very old-fashioned way of you raising your hands if you would like to ask a question. So please go ahead.
Hello, I'm a radiation oncologist, so I'm thrilled of the opportunities that AI can present, especially in my subspecialty, in terms of data collection about toxicities and how to predict these toxicities in order to improve the quality of healthcare. But I have a concern, and this is a question about the danger. My concern is about disparity, but not in terms of users. The disparity is about, for example, us doctors who don't have the proper skills or the AI literacy, if we want to say. How am I going to monitor, to question the results that the AI algorithm will give me? Because I need to have these skills in order to say and to evaluate these results. Are they manipulated? Are they biased? Are they okay? Can I trust these results? Can I trust the data I'm giving it to learn and to predict?
Yeah, okay.
So,
thank you. Okay, thank you. So the question is actually a really interesting one. So it's actually about the disparity amongst healthcare workers, people who don't feel that they have the skill set to interpret or to understand the AI. That would obviously be a very significant concern.
Yeah, I think these things, I guess, I think they are perils, but we have to embrace those perils and see them as risks. And so, I think it's really important that we call them out for what they are. Ultimately, that's a big system thing about education, trying to tackle the reasons for that literacy, trying to make it actually plausible that you can do this in your day job. I meant to make the example earlier. If you imagine you've got a very busy clinic that's overloaded, you're trying to get through it quickly, and something new comes up, or there's a way to take a shortcut, it's to be expected sometimes people will do that. So if your radiologist says there is no recurrence on this scan, are you going to look around every corner of the scan with your own eyes to be sure, or are you going to believe the radiologist who perhaps has seen more scans? But they'll make mistakes, and you should check that. And the same could be true for that AI. Like, how do you work with that AI to not kind of make assumptions and miss an opportunity? So I think it has to be there something about defining the risk and mitigating it, and trying to then work out the best way forwards from that.
Kingsley, it's a good question, isn't it, though, about how sort of healthcare professionals and the literacy of AI and the risks there?
Yeah, so first, if you're deploying any new technology, even if it's an EMR, there has to be support just continuous support till it's just kind of part of the workflow and how they use technology to see their patients. But the second point I'd like to make is the fact that when we have clinical outputs from an AI algorithm, be it generative AI that is fine-tuned for clinical work, there has to be a layer of explainability, and that's the whole concept of explainable AI. So explainability in the sense that you have an output and then you have like a text box that says, these are the reasons why we came to this decision, or this was the clinical guideline that was used, or this was the data and this data that informed this decision. That way, doctors can trust it better because the way physicians work is through evidence, and they just don't want to believe something that came into out of a black box. And also that way, the doctor can also learn if that's like new knowledge for them. It could spark curiosity for them to go back and research, okay, this was what I saw, and this was the explainable. And so there's a whole field. I mean, people even get PhDs in it, in explainable AI, because that is the responsible way, I believe, that AI should be deployed in clinical medicine, including in cancer care.
Thank you. Okay. This lady here in the cream.
Thank you for a really interesting debate. I have two questions. One is very now, and one is into the horizon, and you may or may not have a comment on it. Any further thoughts on mitigating the risks associated with the bias in the existing data sets that are being used to train many AI algorithms? If you could articulate a bit more on that piece. And then way out, or maybe not so way out into the future, any thoughts on mitigating risks such as the rogue algorithms and data security when we enter into the world of quantum computing, which is getting closer and closer every day?
Kingsley, I'm going to ask you to answer that firstly about the bias in algorithms.
Yeah, so, when you look at the parts of the world where there's just massive, AI development and deployment and training, it's usually in, big cities, like, for example, Seattle, where I flew from. And the demographics in those cities, especially for the big teaching hospitals, medical centers, a lot of it is, people of European descent that go there, and that's the data that is used to train. So it might not be very responsive for other ethnic groups. And one thing, first you have to use the data you have. You can't do anything about, you have to use the data you have. But the second step in diversifying that data and training is collaboration. Collaboration with other centers that might be located in areas that see the kind of cases you're seeing, to collaborate and use that anonymized data on a data sharing agreement. It is a long legal process, but to use that and try to diversify that data and see how the outputs are changing over time. The third step is also collaborating internationally, because, for example, if you have, let's say in Miami, for example, there are lots of Cuban, people of Cuban descent, and so let's assume you can't get the kind of data you need. You can, collaborate with another center in Cuba, because a lot of those characteristics might be similar, less, environmental factors. So, international collaboration is very important. And then the fourth is using synthetic data. So you could look at how other diverse data in other settings are, and AI can help synthesize similar characteristics, which is known as synthetic data, to train and fine-tune, the algorithm. And I would say the fifth is also to look at different regional epidemiologies of different things, or different cancer cases of concern, to infuse in your algorithm so that you cover certain rare instances that might not be there. And then in terms of data security, it's a lot of the biggest cloud providers in the world, which, AWS, Google, Microsoft, they are, building technologies that are beating the hackers all the time, and, things that might make that data sleep. It can never be foolproof because as people are building cybersecurity infrastructure, the in quote bad guys are building things to counteract it. So it has to be a constant lookout for what the latest technology is to incorporate in your platform to ensure security. And also just having institutional policies on how patient data is handled and things that we can do to ensure that that confidentiality and security is taken care of.
Richard, I'm just going to ask you to answer on the data security side of things, the lady's second question.
Yeah. So I guess there's the bit about where are we trying to work with that data. So that comment you made about we need to validate things in other data sets, I think that's really true. It's far more difficult than it should be. It takes months. We get lots of approaches, and it takes months to sort of think about how to move data around with legal and sort of governance. And so that is basically about safety, and increasingly that concept of cloud-based data analysis that stays within the patient side sort of firewall, so within the national health, within the hospital, so you can bring those companies in to kind of test the algorithms, but within a kind of a safe data environment. So I think we're going to see things like that coming together. And that issue of whether we see the performance of the algorithms stay the same, I think it's important we have methods of monitoring for that drift. So if you've got an environment where companies can come compare products, if you've got some way of dashboarding, the performance is slipping for some reason, you can then sort of try to understand why that is. So I think all of these different approaches, we should be building these in now. Have environments within the right hospitals where an AI algorithm comes and you just plonk it into this environment and you can test it, you can monitor it, the data doesn't move out and stays safe.
Thank you. Okay, I'll take another question. Yes.
Well,
it's working.
My name is Twali Ngoma from Tanzania. I want to thank the debaters for good debating. Before you started the debate, I thought I knew about AI and I was thinking of progress only. And now after the debate, I'm a bit confused a bit. I wanted both of you to tell me what you mean exactly by AI, and is it progress of people or things, or peril or people or things? What are we talking about? Which are we addressing people? Is it adding value to people, to things, or something like that? So that I can make up my mind whether in this debate you, Kingsley, won or he won. Tell me, I'm a bit confused,
It's actually a very good, I think it's a very valid question. When we talk about AI, actually, what are we talking about? Kingsley, tell us. What are we talking about? Are we talking about Google Maps? Are we talking, what are we talking about when we talk about AI?
So AI is essentially a computer program that is designed with an algorithm, like a decision-making algorithm, and fed with data that enables that decision so that it can simulate the way we humans make decisions. That's what, that's the simplest way I would explain it. We use it every day from putting locations in your Google map and it's predicting the time you use to get there based on the distance, the traffic conditions, and all that. It's getting to that decision because it has learned over time when the traffic is like this or like that, when you're going to get there, and it makes a prediction of when you likely get there. So in terms of healthcare, this is the kind of things we're trying to sort of simulate in healthcare. As a clinician, you make a decision. If a patient comes to your clinic in Tanzania and they have fever, they have some night sweats, some vomiting, the first thing you start thinking about is malaria, because first your decision-making algorithm was that this is a malaria endemic zone. Fever is one key thing. So the first differential diagnosis you have is malaria, and that's how AI also makes that decision, because it has seen these patterns, and it says, okay, if a patient have this is most likely what it is, and these are the other things that the patient could have, and then you can do more investigations, to really hone down on your diagnosis. So that decision-making tree and the data that is used to come to that decision is how AI works in the clinical context.
Okay, That was very good. I'm going to take,
Can
oh,
I
yeah,
throw a
go on.
quick comment there?
Yeah?
I guess the one thing to say, you have to be very careful about accepting a talk that's a debate, because the question is never answerable. So that is sort of part of the issue there. So I think what we're focused on here is, for me, are the perils significant enough that we need to focus on those rather than getting too excited about the progress? But Kingsley might challenge that.
Okay, I'm going to take one final question, and then we're going to ask our speakers to sum up. I don't know if the microphone is on.
I'm Hisham Ghaffar from the University of Chicago Institute of Precision Health and Population Health. I want to ask about two parts, the explainable AI as well as the synthetic data. So with explainable AI, while we might say we want people to do that, the reality is most companies do not go back and actually make their AI explainable. So one of the big examples is Sybil from MassGen and MIT. They have a great predictive value for, I think it was 86% for lung cancer, but they say it is a black box. We don't know how this is happening. And I'm wondering, if we are giving this to patients, do we then end up eroding trust with our patients? And we don't know where to start to actually explain it. So should we withhold a tool that we have from patients till we can explain it, or do we build it in? And then with the point about synthetic data, because synthetic data is much more like, or is essentially exposed to hallucination, we then expose the most vulnerable to it, making it even worse, because if you go to somewhere like Africa and start doing synthetic data, you have likely more hallucination. So are we making the vulnerable even more vulnerable by exposing them to AI? Thank you.
Thank you so much. So I'm just going to ask you to talk about the explainable AI side of things, please.
No, I think that's an excellent question. I'm quite familiar with Sybil and the team at MIT that developed that. So it's still an evolving field. Where the science have gone is we need to build AI that can make AI explainable based on the decision-making tree behind. In terms of generative AI, there are certain instances that even the people that developed it do not even know how it came to certain conclusions, even if those conclusions are actually right. So the key thing is looking at the validation, even though it's a black box, and they haven't figured out how to make it explainable, because Sybil has it's been very well validated, and building on that evidence. And if, as a clinician, you're using the tool and you start seeing deviation from what your clinical judgment is, then it's something that the developers can review and see how to fine-tune it to ensure that it's meeting the standards. But the future in deployment of clinical AI will definitely require explainability, because that is exactly how doctors make their judgments. And having black box outputs might not really be helpful in trust, even though it has been validated. And so as we move along the journey in the evolution of artificial intelligence, there will be more emphasis, and there'll be more developers and companies actually really looking at explainable AI.
And Richard, you talk to us about trust and explainable AI.
Yeah, and can I come into that synthetic data bit to answer that? So traditionally, I think you've mentioned synthetic data as a solution when you don't have data. But I think there's an opportunity there. Synthetic data is controllable, right? It's a fixed entity when you have a black box that you can't explain. So if you can kind of manipulate that synthetic data in a very structured way, it might give you something on the other side that helps you to understand what you're seeing. So that experiment where they put an elephant on the scan and see if the radiologist sees it. So what happens if you put an elephant into the scan and then the AI sees this elephant? How does it respond? So it's a kind of also potentially a way of thinking, what am I putting in a controlled way? Can I infer anything from what comes out?
Thank you. Okay, so I'm going to go straight back to you and ask you, Richard, to sum up for our audience your side of the arguments about the perils of AI in cancer care.
Okay, well thanks for an excellent colleague. That has been a really great opportunity to talk through this. I think there's a huge amount of hype. We're all very excited about AI. I have to confess, I do AI work. I'm very enthusiastic about it. But I think now is the moment when we have to think, if in 5 years these algorithms are successful, we know even sooner something's coming through. What if we're not ready? What if the FDA, the MHRA, all of these governance processes aren't set up? And I think we have a real responsibility now. And the danger is if we don't do that, we're going to create these tools. We'll get to the kind of the nadir of disillusionment, and these things will fall flat. So at the moment that we've got the excitement and the funding, really think we have to develop the clean infrastructure to manage this, the safe governance, really understand what these things are, but then think about the patient and the public perspective and seeking equity in the approaches that we're taking. And then just have a cautious eye. It's great to work with industry when it's equitable, but to be cautious to think about, is it truly equitable, and who's driving the agenda? We've got these great societies. You guys are the international experts in all of your areas. How can you drive what AI is about in each of your fields? And that's the bit, I think, where we need to come together to avoid these dangers.
Thank you so much, Richard. And final word is for you, Kingsley, to say why you believe AI in cancer care is progress.
Yeah, so when I think about other industries, look at the automobile industry, the advertising industry, and just several other industries, AI has really, truly transformed those industries. And healthcare is the one lagging behind every major industry. And that's for good reason. Patient safety must be paramount, if efficacy must be paramount at the back of our minds. But the disparity here I see is that healthcare has the most data. We produce the most data in healthcare. And what are we doing with that data, right? And this is where we're at the time in our civilization where it's just unprecedented that we have to figure out how to build these technologies, mitigate bias, ensure that we can make life more efficient for clinicians, increase access for patients with safety at the back of our minds on everything that we build. And I think we can truly transform cancer care in ways that could improve patient outcomes. And even if the outcomes or the end for a patient is not improved, at least their experience during the cancer treatment journey, even if it's terminal. Patients deserve dignity. They deserve less pain during their treatments. And if we have tools that can support them through that, we definitely have a responsibility to do that. That being said, we need to work with government agencies, especially regulatory agencies, to ensure that the right regulations are in place, but it's at a balance that it doesn't stifle innovation. Thank you.
Thank you so much. So
Yeah.
before we go to our final vote, I would like you all to join me in thanking both of our speakers, who I'm sure you agree gave wonderful insights. Thank you. And I invite you again to vote. You need to use the QR code that is on the screen. AI in cancer control, is it progress or peril? It's time for it to... I know, you see. So quite a change from the start. So that just shows the insights and the viewpoints that we brought to the debate. Still changing, but yeah, it is slightly different. So thank you all very much for coming, and I hope you enjoy the rest of the afternoon. Thank you.
Thank you.
See, you changed.